Health in Uganda is still priority with special emphasis on maternal health care, HIV/AIDS, child health, and malaria prevention. Government expenditure on health in Uganda still stands at about 9%, which is approximately 838 billion shillings out of the 10 trillion shilling national budget for the financial year 2012-2013. These fall short of the Maputo Declaration of 2003, which requires that governments allocate 15% of their budgets to health. According to the Uganda's health policy, every district is supposed to have health centers 1, 2 at the parish level, health center 3 at the sub-county, and health center 4 at the county level to serve the communities. It's impressive to note that while the government has tried to set up these health centers all over the country to improve the general health service delivery, there are still challenges in accountability, empowerment, provision of health information, and services in the districts that civil society organizations hope to address through community monitoring. In order to raise awareness of human rights aspects of health and improve the quality of health and healthcare of all Ugandans, Uganda National Health Consumers Organization, UNHCO, together with the Action Group for Health, Human Rights and HIV/AIDS, AGHA, implemented a preventive program designed to educate communities to promote aspects of their health services to include medicines, human resources, and even demand accountability for health providers. Community monitoring, which was first implemented by AGHA in the districts of Palisa and Liantonde, and by the UNHCO in 2011 in Masaka and Oyam districts. But what is community-based monitoring?
In basic terms, what it means is that communities are empowered to follow up health service delivery, to be able to see whether the service meets their needs, first of all, but also what they can contribute to community monitoring, but also to understand how the system works and how they can benefit in terms of utilization. The bottom line is that service users are able to understand what their entitlements are, what is available, how do they get it, who is responsible for giving them their rights, and what is their responsibility in terms of ensuring that systems deliver effectively and efficiently. And the idea for UNHCO was that there is a forum, that we create a forum, space for community voices to come up and influence the quality of healthcare in partnership with the policymakers and service providers. Right from the ground level at service point to the national level where we represent civil society at the Health Policy Advisory Committee and various Ministry of Health committees. We have also built a coalition of health rights organizations. We call ourselves Voices for Health Rights. And the idea is to influence services right from policy so that policy reflects the rights-based approach, but also that the communities own these services, monitor these services, make sure that there is efficiency and it meets their needs.
The reason why we started this project was because when you look at the national health policy that the Ministry of Health has produced, it really talks about strengthening accountability in the way health services are provided to ensure that health services are of quality, they are acceptable, they are available to the vulnerable groups such as women, children, elderly, and people living with HIV and AIDS. Not only that, AGHA as an organization, our interest or areas of focus really looks at a society where there is equity and social justice, looking at right to health, strengthening and promoting right to health in Uganda.
The tool that has been employed in this project, which is basically a community monitoring project, is the community scorecard. And the community scorecard is one of the social accountability tools that have been used in several other parts of the world engage service users in decision making for the delivery of services at their respective service points.
The community scorecard as a tool of monitoring involves the following steps. First, orientation meetings are held for district and sub-county authorities to raise awareness on health rights and responsibilities in healthcare. The second step involves selection and training of community monitors. Community mobilization and sensitization on health standards, entitlements, rights and responsibilities follows thereafter. Fourthly, healthcare users are subdivided into different focus groups, including women, men and the youth within the same communities, and thereafter an action plan is drawn, implemented and monitored, and the last step is application of follow-up scorecard. Community monitoring, which is designed to ensure stakeholders determine the type of healthcare they attain, does not only benefit health providers but the entire society.
Tugenda mu byalo ebyo okulaba engeri abantu gye beeyambisaamu eddwaliro lyabwe. Tubakubiriza bajje beeyambisa eddwaliro lyabwe ate era bafune n'omutima ogumanya nti eddwaliro lyabwe basobole okulongoosa ebyo ebitambula obubi bibeere nga biba birongoosebwa nga bitambula bulungi.
As a result of their activities is that I think that linkage or that gap has been narrowed. Like for instance, we used to have a number of clients in the lower health facilities, those HIV/AIDS clients. They didn't know that there are certain health services that are being provided, especially at the higher facility like the hospital. So we have seen them over time being linked to the hospital, and they have been accessing the services at the hospital. The other thing that I've also seen is some of the structures at the lower local government, at the health facility like the health center management committees, they didn't very well know their roles and responsibilities. But ever since this group trained them, oriented them on their roles of ensuring that, among other things, they are supposed to link the community that they serve to the health facilities. We have also seen the roles streamlined, because before that they didn't know.
Kituufu ddala ekyusizza kinene nnyo ku bantu ba Mpugwe Trading Center. Ensonga esooka abasawo bwemuba nga kyemuteesezza bakiwuliriza ne baba nga muwuliziganya wamu ne baba nga babakolera bye muba muteesezza. Eddagala balituwa mu bulungi ne wejja essaawa zojjiddemu zobasangawo, naye buli baali bajja leeti, naye bwe twamala okukiteesaako then kati bajja essaawa zennyini ze twateesa.
There has been such a gap of poor attitude of our health workers. So AGHA championed, after having realized the issues that the community had that really were deterring them from accessing health centers. Community has been empowered. They are able to demand for maternity wards. They are able to demand for other infrastructures. For example, issues of blood tests for malaria and other diseases. Because they are able to demand. They also now tell us that no, in this place we lack this, having been empowered by AGHA. It is now demand driven. We are actually having enormous demands because community has been empowered.
A strategy where we involve the people, the local communities, to demand for their rights, to demand for service delivery, has actually helped. Because initially we had people going in hospitals, they would not get medicines, especially at health center 3s and health center 4, and they would not be treated well by the health workers, that is the nurses. But now with this kind of monitoring tool where we involve the stakeholders in this case. We have the nurses, we have the midwives, we have the clinic officers, and we also have the community people, the patients who actually use the services. Once they get in contact and then they say what their problems are, first of all, the community members come to know what facilities are in what health facilities.
Community monitoring has done a vital role in our area, especially when AGHA came in and they introduced the issue of community scorecard, which has been of a very vital role to us. And the aspect actually they have played is on advocacy, on health service delivery, meaning they have linked the health facility or the health providers to the community. Before they came, we didn't have a suggestion box, but when they came in and engaged us, we were able to acquire a suggestion box where we normally receive complaints from our communities, and then they also engaged the sub-county leadership.
Health workers could always be absent, but those ongoing supervisions and monitoring have really kind of motivated the staff. So they are rarely absent, though some of them miss out on some days, but it's really a difference since I came here. And outside of the clients, there is, I think they have created a relationship between the patients and the staff, because the patients can come out and tell the health workers their problems, where they are dissatisfied and where they are satisfied. And they can always, like they did a scorecard. Patients were able to mention what are the bothering issues to them, and so that did the staff.
The water was not enough, the water supply was not enough. The community asked for another water tank, which the community and the community monitors together followed up on. And then before the project there was no electricity, and there was no electricity at the health center, and the community raised that issue. So they followed it up, they wrote letters, and finally they got that electricity at the health center. Another issue that we have seen is the placenta pit, which was also an issue raised, and now it is there. For us, we see that it goes beyond the physical things that we are seeing. It goes beyond seeing the placenta pit, seeing the water tank. It goes beyond that. It goes beyond that to the extent that for us we see that we have a community that is able to say we don't want this, we want this. That is able to say that it is our right to participate in service delivery here at our health center.
Community monitoring, which has been in place for 2 years, has a few hurdles to overcome.
Community monitoring is a new paradigm in Uganda. As you know, Uganda has just started enjoying a democratic process of governance, and you know very well, as community do the monitoring, you demand, and when you demand, it's about seeking for redress of some of the misdeeds that are happening in service delivery. So you find that the community themselves are not yet confident enough to say it is my role and responsibility to go and demand. They feel that seeking a redress for example, lack of medicine in the health facility is the role of elected leader, is the role of a councillor, which is not the case. So we still find that the level of human rights awareness still very low. As you know, a rights-based approach to service delivery is very critical, but our communities down there still feel it is not within their mandate. You find that sometimes politicians, when they see you going to the community, telling the community about their rights, talking about what the Constitution says, what the Local Government Act says, what the National Health Policy says, they feel you're becoming a politician. You are threatening their position. When you're telling people about the budget that has been passed by local government and showing them what budget is going to be implemented this financial year, say for water, let's say for medicine, they feel you are threatening their positions. So that kind of environment still exists.
The challenges that we face are very many, especially on financial ground. Because when a person goes to mobilize the community that please come for a meeting, most of them come expecting to be given what? Money. And when you talk to them, they say, hey, they have called us and they have not given us something. And then health workers at times want to hate the AGHA staff because they do this, they talk about us, they do what?
Though community monitoring has been around for 2 years, there is still a need to strengthen the project and the link between government's expenditure on health and quality of sector outputs. But what is the way forward from the UNHCO, AGHA and the community?
Already we have influenced a lot of organizations. We have influenced the way service is delivered. We have developed the Patients Charter, which is the framework through which communities can engage government. We have influenced Parliament. We have already worked with Parliament on the budget to increase the budget for health. We are already teaching communities that they must demand that there is a place, time, where they meet with service providers and do what we call resource mapping. They find out what is for them. So in the future, we should not remain as a facilitator, as that we want to see the communities take over this role themselves and be able to demand accountability, whether we are there or not, at all levels.
Some of the challenges probably could be on capacity, which we feel should be strengthened. More training should be provided on how to use social accountability tools such as community scorecard, such as citizens report card, social audit, so that we are able to apply social accountability tools in order to enhance community monitoring.
Service delivery is not a one side. You see, if I go to a shop, I'm going to buy, I participate in choosing a kind of shirt I want to buy because there is a certain quality I want. And service delivery is also a commodity you buy. If I'm a passive buyer, I will take whatever I find there. And for health, it's not even like a shirt because this is the difference between life and death. The communities need to be knowing the kind of service, the quality of service and the amount of service that they're supposed to get. If they don't know, and if they are not able to advocate for it, the other person will give whatever is there.